When new clinical trial evidence comes out, we do get alerts from the FDA. We get alerts through ASCO emailers. We also get alerts through NCCN flash updates. Anytime a drug gets FDA approval, or if there's an NCCN guideline change, we immediately make a change in our coverage policy. When we make a positive change for drug approval, so let's say FDA sends us an alert and we start covering the drug, we don't make a specific outreach to the providers to let them know that we're starting coverage for that particular indication. I think the providers also receive alerts from FDA and ASCO when they sign up for their alerts. So we rely on that for the providers to be educated and to be able to request for drug authorization when new FDA approvals come out. We have implemented a patient decision support tool in practice. So the providers have access to a portal where they enter patient data. It collects detailed information on the patient's performance status, their age, demographic information, also collects information on their cancer subtype and all the other relevant details that are required to make a drug approval decision. Once that information is collected, it leads them to a list of choices that are in the NCCN guidelines. If the provider is able to pick one of those drug regimens, there's an automatic authorization. In situations where the provider is not able to pick one of those for whatever clinical reason and is wanting to deviate from one of the regimens that are in the guideline, he or she has the ability to put in a custom regimen request. All of those requests will be reviewed and the provider has an option to have a peer-to-peer discussion with a board-certified medical oncologist to understand any nuances that may be going on with that particular patient to see if there is a reason for a clinically valid exception in that particular scenario. If there is a reasonable clinical reason, then we do allow that exception at this time.